This is Dr. Sargisian, and today we'll talk about hormonal regulation and disorders of hormonal regulations. The focus of the lectures is not the review of content you previously know from undergraduate studies, but focusing on the disorders which haven't been discussed in depth during those studies, as well as disorders like diabetes that have been discussed, but this will give you a slightly different overview of the disorders than you had before. So endocrine system responsible for hormone production, and hormones are nothing but the messengers that help to regulate one or the other system in the body. So as we know from many years ago, when we all were taking AMP, endocrine system is a perfect example of feedback system, and negative or positive sometime. So when we have a dysfunction of any of the endocrine glands, we may have excessive production of the hormone, which may lead to alteration in the body, or insufficient or inadequate production of the hormone, which may lead to alterations. And another problem we can encounter is altered hormone inactivation or degradation. Means the hormone hangs out around quite for a long time and keep working, although we don't need it to work. And degradation means it's just destroyed too fast, so it doesn't have its effect. Ectopic hormone release can occur from the non-endocrine sources, such as autonomous production, where no feedback mechanism are engaged, such as if we have a tumor, for some reason it produces the hormone, and it's because of its malignant or even non-malignant nature, but because of its uncontrolled production, it will continue producing the hormone without any feedback from the body. Another problem we can encounter here is target cell failure, and that's what we see in diabetes type 2, great example, which an example of receptor associated disorder, and or sensitivity disorders also can be good example. So receptors can decrease in number, or their function impair, or antibodies destroy the receptors. And there are antibodies that will attach to this to receptors and to mimic that action, but actually they are not hormones. And another one is quite rare, when the receptor will have unusual expression of the function. Hypothalamus, pituitary system, and this is important for us to understand many different disorders in the body, such as hypo or hyperthyroidism, which you all encounter in your practice or at some level, or if you are teaching future nurses, this is also an important component of teaching, and this can be applied to many other areas, not just primary care, but medical, surgical nursing, acute care nursing, just something as simple as thyroid disorders. So hypothalamus has ability to communicate with anterior pituitary and ask anterior pituitary in turn to release hormones to complete one or the other function. For instance, again in thyroid example, in TRH will be released, and it will result in anterior pituitary producing TSH, and consequently the cascade will kick in, and thyroid will be producing T3 or T3 and subsequently T4. So, or gonadotropin releasing hormone will affect the production of follicle stimulating hormone or luteinizing hormone. To summarize this, we need to know that anterior pituitary is not the origin of this hormone, or not origin of hormonal hormonal messengers. The origin is in hypothalamus and where it's all coming from. So anterior pituitary is another, I can say, roadblock or a pit stop on the way of hormonal messaging. So again, this is the system. Again, we cannot usually, and not usually, sometimes the role of hypothalamus isn't as outlined as here, but you need to know that everything comes from hypothalamus. So when we're talking about pituitary disorders, in the anterior pituitary carries the most or produces the most of the hormones, very few produced in posterior. So pituitary has lots of vessels and it's vascular. It can be vulnerable to ischemia, of course, like heart, and also infarction like heart. Another problem with it, it also can be traumatized fairly easily and hemorrhage. But again, ischemia, infarctions can be significant problems in this, because if we go to the previous slide and see how many other functions, how many hormones pass through or produced by pituitary, it's the damage to it can lead to significant consequences. So if we're having hypopituitarism, it's a rather complicated situation, and it can be a consequence of pituitary infarction related to Sheehan syndrome, hemorrhage, or shock, and other intervention or other factors may affect this, such as trauma or head trauma, infectious, of course, tumors that may provide or may produce significant pressure on pituitary and result in the pituitary dysfunction. Couple of words about Sheehan syndrome. Again, I put it here as a very rare disorder relatively, but people who work in the arena of maternity, labor and delivery, you may have seen a case or two, or I doubt, I never seen one in real life, but I read a lot about it. And Sheehan syndrome is a syndrome of ischemia related to maternal bleeding during childbirth, and the risk factors are having twins or triplets, and ischemia and infarction may result in inability of pituitary to produce any of the hormones, and the treatment is truly the hormone replacement, and again, this may result in pan-hypopituitarism, and means that all hormones are missing from production. So in this case, if we having someone who already has Sheehan syndrome, the treatment will include replacement of all hormones. Again, hypopituitarism can be reflected or materialized in many different ways. As I said, pan-hypopituitarism, like Pan-American, airline, and I know they made a new movie about it, but anyway, but pan means across, and the same is name of the airline, and the same is pan hypopituitarism, means across all hormones that pituitary would produce. So all of the hormones produced here will be missing, and all of them may need replacement. On the other hand, it can be that only some or one of them missing, such as ACTH, TSH, or follicle stimulating hormone, growth hormone deficiency. So depends whichever one. Still, you will call this hypopituitarism. Only time, again, you will call it panhypopituitarism when all of the hormones are absent, like I was describing in Sheehan syndrome. Hyperpituitarism is an opposite condition, and usually it's a consequence of a benign tumor of benign pituitary adenoma. When we're saying benign, we know it's not metastasizing, but what we're facing here in the cranium, in closed space, when we have a tumor growing in the closed space, it may start producing all these symptoms such as headache and fatigue, visual changes because of the pressure on optic nerves possibility. But what we are concerned from the standpoint of hyperpituitarism is the production of the hormones. And in this case, if we have overproduction or underproduction of the hormones, we may see changes in feedback mechanism. Let's talk about hormones separately that come from anterior pituitary. And growth hormone is one of the important hormones that regulate the growth, and there are two disorders related to hypersecretion of growth hormone, and acromegaly occurs only when we have too much production of growth hormone during adulthood, and this is a slowly progressive disease. Acromegaly, it's not childhood disease. The disease slowly progresses, and a patient may die from cardiac hypertrophy, hypertension, atherosclerosis, may develop diabetes, and as a consequence, of course, endothelial dysfunction and coronary artery disease, may have malignancies growing. Giantism is a similar disorder, but this occurs in children and adolescents. The difference is why in one case we have acromegaly and in other case we have giantism, because in giantism the growth plates are not closed, and children or adolescents will start having this growth sprout and growing very significantly. In acromegaly, if GH or growth hormone secretion started in adulthood, there are no open growth plates. However, the parts such as cartilage that's sensitive to growth hormone may grow, such as cartilage in ears, nose, and you will see that those body parts may significantly enlarge, as well as cardiac hypertrophy. And again, another layman theory that big heart is good for your health. Unfortunately, it's not so, and one of your jobs will be, if your patient is diagnosed with this, that when you teach and educate about possible consequences, because this is treatable, but cardiac hypertrophy is one of the possible consequences, and your job is to educate about it. Or any other patient you teaching about cardiac hypertrophy, you need to remember that big heart in healthcare, in medical nursing world, is not a good thing, and big heart needs to be treated. However, in everyday life, we all love a big heart. Let's go back to acromegaly, and again, to focus on it, we can say that connective tissue will proliferate, such as, and again, ears, we also will have enlarged tongue, and sebaceous and sweat glands also start very active life, and coarse skin and body hair. Bony proliferation, large joint arthropathy, and periosteal vertebral growth will start with kyphosis. Facial bones and hands and feet will grow, and protrusion of the lower jaw and forehead. So lower jaw will start growing, and also hands and feet. If the older patient require bigger shoes over and over again, then we may have a problem, especially bigger gloves, and this is and hats. This may be a problem related to acromegaly. So this is part of the history that may slip into your history in physical examination. Of course, I don't really recall that in general physical exam or in general history taking you ask about enlargement of facial bones and hands and feet, but if it slips into the conversation, this is something that needs to be addressed with all seriousness, such as especially enlargement of hands and let's say need for bigger rings, gloves, and enlargement of head and need for bigger hats. Enlargement of the shoe size or need for a bigger shoe size may be just age related, and because colloquially speaking, the older we get, the more comfortable shoes we need. We may need size larger eventually, but again, even in case of feet, increase in the size of shoes more than one size is something to think about, and question more your patient, and if needed, to proceed with diagnostic workup. Another problem can happen with anterior pituitary, hypersecretion of prolactin, and prolactin consequence of prolactinoma, and this is the most common pituitary tumor, and I put here hormonally active. That means this is not only a tumor in pituitary, but it also produces actively the hormones. So if we have a female who produces lots of prolactin, prolactin may cause amenorrhea, galactorrhea, hirsutism, and osteopenia. So in female patient, males do not respond well to prolactin increase at all. This will impair the gonads, and patient will have hypogonadism. Of course, it will impair, if patient is having hypogonadism, the testosterone production is impaired with consequences of erectile dysfunction, libido decrease, oligospermia, and also diminished ejaculative volume. Of course, we listed all these factors here, not just to have something to list, but all of this problem in males is significant, not just because, of course, erectile dysfunction, it's comfort, quality of life, impaired libido, the same, but oligospermia, diminished ejaculate volume, this all may be precursor to infertility. So especially if we have low sperm count, then the probability of conceiving a child becoming lower and lower. So prolactinoma, because of this, at least because of this, for many other reasons, need to be treated.